Kaul has spoken and published extensively on lupus and has participated in several lupus clinical trials. He's a member of the BILAG group, leading on a study on hydroxychloroquine, as well as the British Society for Rheumatology Lupus Guideline Group, and is the chair of the Antiphospholipid Syndrome charity, GHIC. And we're very lucky for him to join us, getting a late night coach last night to come and speak today.
Thank you very much. I feel like Elvis Presley. I don't quite have the cough though. They're not too bad. Thank you very much, Paul, for asking me to talk. And my name's Arvind Kaul. I work in southwest London at St George's University Hospital's NHS Foundation Trust in glorious Tooting. For those of you who used to watch Citizen Kane, it was on the front. Not Citizen Kane. It was Citizen. Was it Citizen Kane or Citizen Smith? What was it? Citizen Smith. Yeah, somebody watched it. That was the tube station at the front of the credits. I'm showing my age. I can't even remember the program. So lupus. So lupus. Clinical features. You'll all know this is really, really complicated, and all of you will have lupus, and we call it lupus, but it will be very different probably in each of you. And it's best probably not to think of it as one condition. It probably is several conditions. And there are numerous overlaps, and each of you may have your own separate type of overlap. And you may have other conditions which magnify the symptoms and add to the burden of the way you feel. Simply things like Sjogren's syndrome, dry eyes, dry mouth, scleroderma, a much rarer condition than lupus, myositis or inflammatory muscle disease, rheumatoid arthritis, some of you will have, overlapping with lupus. It's not simple. These are all best buddies. They hang around together. And it can be quite challenging to not only diagnose lupus, but actually distinguish what is lupus from some of these other conditions. So I make no apologies for putting that up, because that graph is totally indecipherable. What the hell is it? And that's exactly the way lupus can be. It can be extraordinarily complex, and each of those points on the picture can vary. Some people are light sensitive, and that's their trigger. Some people have infection as their trigger. Some people, there is no obvious trigger. Each of you will produce different antibodies. Sometimes there'll be aberrant problems with T cells, which are part of the immune system. Sometimes it will be the neutrophils. And it doesn't have to be the same thing at each of you. So genetics vary. Afro-Caribbean heritage and the Southeast Asian heritage tend to get more severe lupus. There are environmental factors like sunshine, sunlight, drugs can influence this. And then you've got your comorbid conditions, all the things that add to the burden, like diabetes, thyroid problems, all of which add to what's going on with your lupus. And so you can see explaining blood tests is not always going to be that straightforward. And this takes years for me to learn, so I'm going to have to do it in 25 minutes. Let's see how that goes. So the critical thing, I think, from the outset is, how do I interpret blood tests with lupus? And the blood tests, I think, really have to be seen in context. So patient history, what you tell me, is really important. Because quite often you may have a skin rash sometimes, but it's not evident when I see you. You might have joint pain, but it might be a little bit better when you're seen. So patient history, clinical examination, and tests are all utilised together to help diagnose and monitor lupus. It's not a good idea to look at one in isolation. So how many of you have a positive antinuclear antibody that you know of? Yeah, most of you will have that test done. But there will be other tests that the rheumatologist will do, outlined here, which include double-stranded DNA, which we'll come to in a minute, and complement, immunoglobulins. These may all sound like gobbledygook, but they're all very, very important together in outlining how we manage individuals' lupus. And then you've got the routine tests, which can't be discounted. And these are things that your GP will do before you're even referred. And quite often these can be very, very important also to give clues as to how lupus can be diagnosed in individuals. Now, part of the issue that we have, when I get referred patients, sometimes you have a positive blood test, sometimes more than one positive blood test. And they're completely well. They're sitting in front of me thinking, why am I here? And I'm thinking, well, I don't know. And then I look at the blood test, and the patient's been referred because by chance they've been found to have lupus blood tests. And what we know about lupus blood tests is they can be found well ahead of the diagnosis of lupus. So this was a very clever study that looked at blood tests. In the US Army, blood tests are taken when you enlist and they're stored for future reference. And this group looked at people who were diagnosed with lupus in the US Army and then thought, well, let's look back and see what their blood test showed all those years ago when they enlisted. Very clever. So what they found is a significant proportion of people actually had very positive blood tests for lupus, one or more, well before they were actually diagnosed with lupus. So this is a kind of a brewing process. And it also then means that if you find these blood tests by chance, patients may have some symptoms, they may have lupus, but they may actually have nothing at all. And so again, there has to be clarity in terms of what you find clinically and both what the patient tells me and the examination. That has to be put into the context of the blood tests. So what about the antinuclear antibody? This is probably the most talked about antibody because I get a lot of patients who've been referred with a positive antinuclear antibody. This is the sort of pattern that we see. So what is it? You know, what is the test? The test utilizes a particular cell type onto which the patient's blood is put on, and then we use special stains to see if it lights up. And there are different patterns you will see here of antinuclear antibody, and they determine what other antibodies may or may not be present. And these antibodies, the antinuclear antibodies, are found in about 95% of lupus patients, but that's not 100%. So you could technically have ANA negative lupus, and so it's not an absolute form of diagnostics. Now, one of the problems with ANA is it's found in a wide variety of people in the population. So about 15 to 20% of the population in some studies may have lupus. Now, do 15 to 20% of people in the UK have lupus? No, it's about 0.4%, maybe less, maybe a little bit more. Estimates vary. So from 15 to 20% of the population to 0.4% actually having the condition associated with that antibody, there's quite a wide discrepancy. So that tells you automatically an ANA is not a diagnostic test. So it doesn't give you a diagnosis. So you've got to put it together with the clinical features. Now, if you had an ingrown toenail and you saw me and somebody said, oh, you've got a positive ANA, hands up who thinks that's lupus. 0%, well done. But if you've got an ingrown toenail and an ANA positive, and you've got alopecia, and you've got skin rash, which is sunlight sensitive, and you've got joint pains, and you've got fatigue and tiredness and Raynaud's, hands up who think that might be lupus. Absolutely. You don't need me, you know this all. Now, this is Eurovision, okay? So, am I going to give this test 0 points? So, the Kaul usefulness scale is extensively validated. I thought of it at breakfast this morning and added this on. So in terms of diagnosis, I would give it a 5 out of 10. Okay, yeah, it's useful, but in the right context. And lots of people will have ANA and will not have lupus. In terms of monitoring, less useful because you might have a positive ANA and be diagnosed for years. Eventually, lots of people do, with treatment and time, get a negative ANA, but they can still get a flare-up. So it's not that great for monitoring. Now, all of these other things that you'll see on the left are different antibodies where you've had a positive ANA and sometimes the negative ANAs. So these are called extractable nuclear antigens, and your rheumatologist should do this as a routine for anybody that has symptoms of lupus. Now, these are highly relevant to lupus quite often. So the anti-SM antibody, for example, is very specific for lupus. It gives us a good indication, again, that somebody might have lupus, but only in the right clinical context. So I've seen patients who've got SM antibodies are pretty well, no real problems. They don't have lupus until they've got the right clinical features. So remember, these tests are great, but in the right context. Kaul usefulness scale, diagnosis 7. They're really useful. If somebody's got an anti-SM antibody and an ANA positive, together with the right features, I'm pretty confident that's going to be lupus. Monitoring, not so good. So you can't really use these again and again to say, how's the lupus doing? So they're not so good for that. Immunoglobulins, remember this complicated diagram on the right, indecipherable. Part of that process is producing antibodies, and antibodies to all of these ANAs, for example, antibodies to other non-specific markers. Immunoglobulins are antibodies that you produce which can be measured, and they're often high in lupus, and they can go really high in some patients, and worryingly high. You think there's something nasty going on, but it's usually always lupus. But again, they're great for diagnosis. If they're raised, that tells me that your immune system is working overtime, which is really what lupus is. They're useful in that context, but they can be raised in other conditions as well. Monitoring, again, not so great. It's not particularly useful for monitoring, but they're there, and we use them to try and diagnose lupus, and also to get an idea of whether they're going up or down, or whether there's something suspicious going on if they are going up. So they're useful markers. Now, what about monitoring? We've talked about diagnoses, and all of the previous tests are primarily diagnostic. Are there tests that we use to say, well, your lupus is better, or your lupus is not better? Now, there's no perfect answer to this, but one of the tests that you will undoubtedly all have been tested for is double-stranded DNA, or dsDNA. Now, this provides a lot of angst to a lot of people, because they look at their blood tests, and with the GP portals, you'll all have blood tests available, and you'll think, oh, double-stranded DNA has gone up. That means my lupus must be worse. No, it doesn't. Okay, so what's the golden rule here? You must have the right symptoms, and there may be other tests which also indicate that your lupus is worse. So I've given 3 examples here of patients where it's actually can be helpful, but it isn't always. So patient 1, the double-stranded DNA was very high, over 300, all the time. It never varied. Clinically, patients very, very well. Never had any particular issues. Double-stranded DNA is often related to kidney disease, so we can use it as a marker in those kind of patients. Patient 2, the double-stranded DNA was over 300, very strongly positive. And you think, oh yeah, it's not great. But then became slowly negative with treatment, but then had a massive flare-up with the kidneys. And the double-stranded DNA didn't really rise that much, a little bit, but not extensively to 300. So it wasn't a great marker for that patient. And patient 3 on dialysis had a flare of her lupus, and the double-stranded DNA rose from 53 to 160. So in that patient, it was actually quite a reliable marker. So you can see it's not a straightforward exercise that levels go up and therefore your lupus must be worse. You're often the best judge of what your lupus is doing. Because if you've got more joint pain, your hair's falling out, you've got mouth ulcers, listen, I don't really need a blood test to answer the question of, is my lupus more active? It is, because you told me it is. So what about other tests? So complement, you all look lovely by the way. It's not that kind of compliment. These are defense proteins in your bloodstream, and they are normal constituents of your immune system, and they get used up in infection, because complement attacks bacteria. But because lupus is an overactivity of the immune system, it's almost like having an infection without the infection. Complement, of course, gets used up. And we measure that, and it can be a reasonably reliable marker of disease activity. So the complement, as a trend goes down, it can indicate that the lupus may be becoming more active, but again, in the right context, and that is important. So there's another usefulness for antibodies, and that's inferring what type of lupus you might get. And there are some links to antibodies which may be helpful, as Chris's neuropsychiatric lupus talk. For those kinds of patients that have neuropsychiatric lupus, there are some antibodies, ribosomal P antibodies, which we don't routinely measure, but may be present. For kidney disease, double-stranded DNA and anti-SM, as we've mentioned. For skin disease and photosensitivity, the Rho antibody is often quite a useful marker of detecting whether somebody might be more prone to photosensitivity. And you can see there are links with other antibodies which may be useful for us as doctors to say, well, maybe you're more prone to getting this, or if you're photosensitive, well, you've got the Rho antibody. So you may be able to infer the type of lupus that somebody has from the antibodies, but again, it's not always straightforward. I put the heart scan on the left and the baby on the right, and I've labelled them just in case you're a bit confused. So the heart scan on the left, don't worry about the arrows, but basically what that shows is what's called heart block. The upper and lower chambers of the heart are not beating in synchrony. They're not communicating, so they just do their own thing. And that's called complete heart block. If people have the Rho antibody, I say people, I mean women, because you've got to be pregnant for this one. If women have the Rho antibody, there's a 2% risk that it will cross the placenta and may cause this condition on the right, which is neonatal lupus. Now, the skin rash is part of that, and that disappears, so there's not a problem. But what it can do is cause damage to the baby's electrical conduction system and cause this heart block. And hydroxychloroquine, one of the drugs that we use routinely in lupus, is reasonably effective at trying to reduce that risk. But it can't be entirely prevented, and it can still happen. You need to be seen by a fetal cardiologist to have fetal ultrasound done routinely from week 16. And so the Rho antibody may predict that, but it's only in 2% of people. So there is a prediction ability for some of these antibodies, which is useful. What about the more routine blood tests? And the GPs will be doing these fairly routinely, quite often in patients with lupus and not with lupus. And these are often quite useful, actually. We shouldn't discount them. We're worried about double-stranded DNA and all the other ENA and ANA, but actually these are very, very useful in routine care. So hemoglobin, white blood cell, and platelet count are the three that I most commonly look for. And these basically show how the bone marrow is working. Now, you might think, well, what's the bone marrow got to do with it? Well, remember, all your immune cells come from your bone marrow, and any insult, like infection, for example, many drugs, for example, affect how the bone marrow works. And so even before people are diagnosed, some of these markers can be a little bit low. So the hemoglobin often drops, the platelets can get very, very low on their own, and white blood cells can be even lower. And we often detect that even before diagnosis in people who we think are susceptible. And there's the influence also of therapy, so drugs, etc., that you're given, like methotrexate, azathioprine, will also affect these markers. So these are actually really, really useful tests, even though they're not as specific as double-stranded DNA. So here what we see is a drug, mycophenolate, has been added in, and you can see on the right, the WBC, the first one that goes blue at the top, that's abnormal. And the drug has caused this problem. So the drug has reduced the white cell count. So this isn't lupus primarily, this is the drug. Now, on the other hand, On the top graph here, the greens, by the way, are normal, and the red and blue are out of range, in case you can't see this all. But the lupus has actually caused the blood count abnormalities on the bottom of the top graph, and then when we've given a drug, that's actually improved significantly because the lupus has improved. So again, this is a really good way of looking at lupus in the right context, of course, to see if the blood tests actually are improving. Double-stranded DNA added in, complement added in, all of these can also be useful, but this is a really easy way of saying, well, is your lupus getting better? And we can see from the blood count that it's definitely getting better on that patient at the top. On the patient at the bottom, you can see the blood count has actually been completely normal here. But if you go up, it becomes abnormal, and that's because the patient has had a flare. And so their blood count has dropped, and their platelet count has also dropped. That's the third column here, that's also dropped. So this has been actually quite a reliable way of determining whether somebody's actually having a flare. And they've had a flare, they were given steroids right at the top, and you can see their blood count has normalized all of a sudden. So this is very, very useful. And these are routine tests your GP can often do. Urea and electrolytes, I won't talk too much because we've got a real expert coming next. So I'm not going to talk too much about this, but these are the way that your kidneys behave. And urea electrolytes comprise sodium, potassium, urea, creatinine. And this is one of our patients who had a bad flare of the kidneys, and you can see at the bottom the kidneys were working well, and the leakage of protein, called the urine protein creatinine ratio, has increased. And these are tests that we use every time a patient comes through into our clinic. You should have a urine test. How many of you have urine tests routinely when you go into your lupus clinics? How many of you don't? Quite a lot. So this is really useful, and this is often a missed test. The urine, not the blood test. For me, I'm not a renal expert, I'm probably talking out of my hat, but the urine is a really, really sensitive way of looking at what the kidneys are doing. Okay? In fact, I would probably prefer a urine test to the blood test, because you probably had a blood test 3 months before, and I can look at that, and if the urine is clear, I'm reasonably comfortable as a rheumatologist. What do I know about the kidneys? So, the ESR, so ESR is erythrocyte sedimentation rate, and this is often raised in lupus. And the next test, the ESR and CRP, are 2 inflammatory markers. And as rheumatologists, we will do these as paired samples. Now, if you come in through A&E, they will never do an ESR. They'll always do the C-reactive protein. But I keep telling them, do the ESR for lupus patients. I need to know, because the paired sample is important. You need to have an ESR and CRP. And there's a reason for that. And that's because patients who have a lupus flare, the ESR will rise, but there are only very few circumstances where the CRP, the next test here, C-reactive protein, will rise. So the ESR will rise high, but the CRP may not go up very much in a lupus flare. In most other conditions like infection, the ESR and the CRP rise together. So you can distinguish what is a lupus flare in a lupus patient from infection, and that's really important in an acute setting. Because you want to know, has somebody got an infection or have they got a lupus flare, because the treatment is different. So the ESR and the C-reactive protein are 2 really useful tests, which you should have really every time you have a flare or any other change in management or treatment. There are some forms of lupus, particularly serositis or pleurisy, for example, where the CRP can rise a little bit, but usually not above 40 or 50, whereas with infection it will go up to 300. So you can see, so this is quite a good discriminator of infection and other forms of unwellness compared to a lupus flare. So I'm just going to wind up slowly, and happy to take questions afterwards. There are 3 or 4 slides which I think show some of the pitfalls as well. How useful are the tests in management? So the golden rule, the take-home message, if you like, really is what you tell me is really important, okay? I'm not going to look at a blood test, and I know some of you tell me, some of your doctors do this. They look at your blood test and say, nothing wrong with you. Whereas your really unwell. So looking at blood tests in isolation is not a good idea, ever. You've got to look at what the patient's telling you, the clinical features, what the heart sounds like, what the chest sounds like, how tender the joints are, and put it together with the tests. And as I mentioned, broken finger with positive ANA is not lupus, unless you've got the right symptoms. The complexity of how we monitor lupus is reflected in the way that we assess lupus disease activity. For rheumatoid arthritis, it's dead simple. You measure the tender and swollen joints, you say what the ESR blood test is, and you ask the patient how unwell they are, and you combine that into a nice round score. For lupus, it's much more complex. On the left is the SLEDI score, or SLE Disease Activity Index, and on the right, the BILAG score. And these are multi-dimensional scoring instruments that are not routinely used, the SLEDI probably more commonly, but reflect the complexity of lupus. You've got seizures, psychosis, joint pains, arthritis, hematuria, blood in the urine. You've got loads of markers, all of which need to be put together, all of which have slightly different weights to them to get an activity index of how active the lupus is. And you can see from these activity indices that the blood tests on the lower bit of this, which you may or may not be able to see, actually weighted much lower than the clinical features. Just pointing out the clinical features are really, really essential. So seizure, psychosis, visual disturbances, lupus headache, all of these are weighted, the clinical features are weighted much more than the blood test features. Okay? So again, the take-home message, what you say is really equally important as the blood tests. I'm just going to briefly finish off, because this came up, I think Wendy had mentioned this as well, about classification criteria. You know, looking at what are the criteria for lupus. And on the left, you've got what are called the EULAR, ACR classification criteria. These are groups of people that have got together to say, well, how can we diagnose lupus, but specifically not diagnose it in a routine clinic, but diagnose it for clinical trials. Now, clinical trials are specific because you need to know whoever's going into your clinical trial definitely has lupus, cannot be anything else. So you've got to exclude a lot of people who may still have lupus but may not fit the criteria. And it's really important that we don't look at these criteria and say somebody's got lupus or they haven't got lupus, because these are for clinical trials, they're not for routine usage in the real world. And this is one of the pitfalls with using classification criteria. There are no diagnostic criteria for lupus. There's nothing in the real world that we can say, I can score this, you've definitely got lupus. There is nothing there in terms of diagnostic criteria for real world practice. Just classification criteria from those groupings that I've mentioned, which are for clinical trials. Now, if we use that ACR EULAR classification to diagnose somebody in the real world, this is a 36-year-old, this is a real case, who was unwell for 2 years, joint pains, Raynaud's, chest pain, hair loss, all the things you might expect of lupus. His kidney biopsy showed obvious class 4 kidney disease, so a very aggressive form of kidney disease. But blow me, his ANA was negative, and we've measured it about 5,000 times, and it's still negative. Okay, so now if you look back, the ACR criteria say you've got to have an ANA positive to be diagnosed in the first place. So all the other criteria are not valid unless you're ANA positive. Now, according to the EULAR classification criteria, he's got class 4 lupus nephritis. He would score 10 on that criteria and he would have lupus. So he's got lupus according to his kidney biopsy. And his total score will be 18 according to that criteria. Definite lupus, but his ANA is negative criteria because his ANA is negative, so he wouldn't have lupus. So, you know, it's all confusing, isn't it? So don't even think about classification criteria to diagnose lupus. In the real world, we get a lot of patients with a lot of symptoms, and because of this graph, we know that antibodies occur well before formal diagnosis, and therefore it's best to think of lupus and autoimmune conditions not as one condition, but as a big spectrum. And can you be 10% pregnant? Hands up. Does anybody know the answer? Somebody must. Can you be 50% pregnant? No, but you can have 10% of an autoimmune condition, 50% or 100%. Okay, so you can be categorized according to what symptoms you have. So these are real-world cases, by the way. So patient 1, age 36, blood test showed ANA, Rho positive, double-stranded DNA positive. You think this has got to be lupus. Sits in front of me, I'm well, doctor, nothing wrong with me. Thank you, you do not have lupus. Okay? Patient 2 has exactly the same blood test. Has fatigue, tiredness, aches, pains in the muscles, skin rash on the face. The dermatologist thinks it's probably rosacea, not lupus. White cell count's a little bit low, neutrophils a little bit low. It's all pointing towards that, but not enough symptoms really for me to say definite lupus, because this could go anywhere, and fatigue is extraordinarily common. So I would categorize this as an undifferentiated connective tissue disease. In other words, not formally lupus, but it's kind of heading that way. The risk of going from undifferentiated to full-blown lupus is worst in the first 4 or 5 years. If I say somebody's got mild version, it's almost like lupus light, 4 or 5 years later, if then nothing's happened, then it's very unlikely to happen. Doesn't mean zero probability, but very unlikely. So I do follow these patients up, and I treat them, because they've got symptoms. Then you've got patient 3, aged 26, ANA, Rho, double-stranded DNA, exactly like the others. But it's got joint pains, hands, ankles, photosensitive skin rash, hair loss, prominent fatigue. It's got fluid in the lungs, fluid in the heart, needed steroids, got better. Oh God, that's lupus, no doubt about it. Okay? Far more symptoms than patient 2. And then patient 4, who's got exactly the same blood tests, joint pains, fatigue, frequent mouth ulcers, but has also got kidney problems with class 4 lupus nephritis and anemia as well. And that's severe lupus. So from no diagnosis to severe lupus with exactly the same antibodies. Okay, so what's the difference? Well, we don't know why there's a difference in terms of clinical factors, but there is certainly a difference in the way that those antibodies can be perceived in those patients. So don't use antibodies alone to measure how active lupus is. And I think that's the take-home message. This is a very holistic way of looking at lupus management, not just about the blood test. If your doctor is saying your blood test's fine, don't worry about it, you're fine, it's not the right way to manage lupus. Okay? So assessing lupus requires those 3 features: your history, the clinical examination, and the tests all put together. Looking at tests alone can be really unhelpful. And you really need to have a holistic approach in combining blood tests and clinical changes to interpret how active your lupus is. So thank you.